the differences, particularly for COVID-19 patients. So this is the scope of my talk. I will also be highlighting what we do and the challenges that we face for resuscitation of COVID-19 patients. So why are we talking about code blue in COVID-19, or why do we need to even prepare for it? It's because it is a very stressful situation. Even without the COVID-19, it is stressful itself. And the code blue scenario is an aerosol generating procedure. It involves CPR, mask ventilation, and intubation, and it is highly aerosol generating. And the most important thing is that there is this great urgency to attend to the patient, but it is like intrinsic to us that we feel that there's a need to rush to the patient that contradicts the need to wear PPE properly. But we need to change our mindset now, that we need to do both properly. We need to wear PPE properly, then attend to the patient promptly, particularly in the COVID-19 suspect and confirmed cases. So this is the guideline published in AHA earlier this month on ACLS for COVID-19. I'm going to go through some detail of this guideline. So essentially, this guideline focuses on minimizing the duration and extent of AGPs, the CPR, mask ventilation, and intubation, and also minimize the staff exposure. And by minimizing the staff exposure, we are actually optimizing our resource management. We optimize the need for PPE when we limit the personnel who attend to the cardiac arrest. So it is not very different from what we do usually. We assess danger, and if we see the danger, we don our PPE properly. We don't go into the danger before we don our PPE. The next thing that we do is to prioritize intubation. That is based on the assumption that by intubating the patient with a cuff ETT and having a good seal, we can actually minimize the extent of AGP. So what we do is that once we enter to the resuscitation room, we prepare to intubate. We put on the oxygen mask on the patient while we prepare to intubate to minimize the extent of aerosolization. And in between, we can still give our shocks and CPR. And we then prioritize our intubation once the preparation is done. So the details, how do we intubate the patient? So we want to have the first intubation to be most successful trial. So the intubator must be the most experienced person.
Pero paano, hindi naman yung COVID room ang pinag-usapan natin.
Yes, viral load kasi kung asymptomatic yan. Yes,
so, pagka gano'n,
could you close your mics, please?
Yes, viral load.
Please close your mics.
Sa asymptomatic, low risk patient, tapos nakahood ka lang, okay lang yun na tanggalin mo yung gown na gano'n, naka-scrub suit ka dun sa loob ng operating theater.
Kaya nga yung anesthesia mismo, yung anesthesiologist mismo, i-minimize na yung intubation and extubation. How do you do that? With the wet gauze, with the plastic drape, with the aerosol box, with all the recotitos. Kumbaga, i-minimize mo naman yung aerosol.
Okay, now you unmute. Thang Wai, just a minute. Go to the top, go to the top, all the way to the top, all the way to the top. Okay. Okay, Thang Wai, you can continue.
Yeah, so we were talking about how do we intubate in a code blue situation in order to intubation. So we recommend video laryngoscopy so that the chances of successful intubation is higher. The other reason of using a video laryngoscope is also to use a disposable scope where we minimize the risk of transmission to the next person. And once we intubated the suspect or confirmed case, we recommend using a closed circuit and connecting it to the ventilator and minimizing the disconnection of the whole circuit. After which, we may want to consider using mechanical compression device. This will at least this will minimize the exposure to at least 2 staff, so that we can remove 2 staff from rotating from doing the CPR. So, so what do we wear? What is our PPE for Code Blue then? So, for Code Blue, it is involve a lot of AGP. So this is the guideline by WHO. So WHO advocate using N95 or FFP2 or equivalent, eye protection, long sleeve gloves and long sleeve gowns and gloves. So this is similar to what we are practicing for our standard exposure to our patient even without the AGPs. So this is another guideline by BMJ. Essentially, it's a similar thing, PPE for AGPs. The minimum standard is N95 or FFP2 along with the gown, eye protection, and gloves. This is a publication by Circulation, again, early this month. I just want to highlight that for confirmed cases, it is straightforward. We will don our PPE, but in a situation where we are called to attend for a Code Blue situation, we must be mindful that there may be suspected cases that we may not even label them as suspects. So just be mindful that in any case, we need to think about whether we should don appropriate PPE or when should we don what PPE during the code situation. I'm going to move on talking a little bit about our experience in NUH. So fortunately, we have not had any Code Blue COVID patients in the OT. Our experience are mainly through training, and we focuses a lot about training, simulation, and we use that to improve our workflow and logistic arrangements. So all our anesthetists actually participated in protected Code Blue simulation. We do it in the ICU setting because all our anesthetists will be deployed to the pandemic ICU. So for our PPE is that we use a standard PPE which involves N95 eye protection, full body gown and gloves for all COVID patient contact, even without AGPs. And for AGPs, we advocate using the PAPRs, provided the users are trained. And I want to emphasize that the doffing process is actually the riskiest process, because when we don, we are fresh and we pay particular attention. But after a Code Blue, we may be tired, we may be distracted, we may be emotionally involved, and we may not take note of doffing a lot of time. So we just need to be mindful that doffing is a risky procedure. This is the graph, this is the data that we collected in the first 6 runs of simulation that we conducted. We conducted more than 20 runs of simulation since the beginning of this pandemic. So I will just go through this graph. So the blue line at the bottom indicates the time of the first responder to don PPE and attend to the patient before the Code Blue. So this PPE involves N95, full body gown, eye protection, and glove. This is without the PAPR. And the average time ranges from about 40 seconds to near 3 minutes. The second line is the red line. The red line is the time taken from Code Blue activation to the Code Blue responder attending to the patient with PPE and PAPR. So the time taken is ranging from 3 minutes to about 5 minutes. So the wearing of PAPR itself does give a little bit of delay. And the last line here, the purple line, is the time taken from cardiac arrest to successful intubation. And this timing gives us some clue about how long will the first responder be doing CPR alone, or what do we wear in the ICU setting. So in our institution, because we wear N95 with eye protection gown and glove, even without AGPs, so our first responder can start to do CPR before the code blue response team arrives. If we don't wear the N95, then we may not be able to do CPR immediately, and that will cause another about 5 to 10 minutes delay for the patient without any mask ventilation or CPR. It also tells us that this is a simulation setting where everyone is ready and everyone is just waiting for the code blue activation and ready to don the PAPR. So when we are ready to don the PAPR, it takes us about 3 to 5 minutes to put it on. But in a real situation, it will take another 5 to 10 minutes extra. So then the first responder nurse will essentially be doing about 10 minutes of CPR alone in a resusc situation. The next thing I want to highlight is actually the trend. So interestingly is that we find that there's significant improvement in the timing after second or third round of simulation, and all the simulation involve new participants. They have not participated in the previous simulation. And we think this is because we actually do daily huddles in ICU, updating each other about the common mistakes that we make. And we also change the layout of the setting, the environment, to improve our PPE and PAPR donning and doffing. So this is an important consideration with regards to your team allocation or team management. If there is a need of rapid training, perhaps every single team of every shift should consist of someone who is trained, so that this someone can actually spread the information about how to don properly and improve the overall safety of the entire team. So this is what we actually improved on the ground level. So we note that in terms of infection control, the common errors that we make are like we forgot to wear our eye protection, particularly for staff who wears spectacles, or we have poor compliance in the hand hygienes, and so we make we make changes to the layout so that the hand hygiene compliance can be better. So for example, the hand rub at the bottom of the at the room door and just next to where we don and doff off the PPE, we put biohazard bins just next to the doffing area. We also put reflective surfaces or mirror where possible, so that we have so that the code blue team or the staff can look at themselves before they enter to the isolation room, and making sure that they don appropriate PPE. One of the things that we highlighted was communication. So we really can't hear each other when we are in PAPR, or we may not even recognize one another when we are in PAPR. This is a baby monitor, the picture here, that we tried using in our ICU setting. It is good in a non-resus situation, but in a resus situation, you may not be able to hear each other clearly because of the background noise. So in a resus situation, we still use whiteboards to facilitate communication. Apart from that, we do logistic improvements. So to minimize the staff movement, to minimize door opening and closing, we pack items. So for example, mini resus trolley, IA insertion packages, intubation packages, so that we put things together and we minimize the missing of items and minimize the need to ask for the runner to bring extra equipment to the ICU or the operating theatre. This will also minimize unnecessary contamination of the equipment. Yeah, so I just want to end with this. This is a article that is just published early this month. It highlights that in the pandemic, there need to be a change of mindset that from doing CPR of trying is doing no harm to there may be significant and potential harm to staff. And in this scenario, doing no harm is not enough. We need to do enough to make sure that the healthcare workers are protected and to ensure the best outcome to our patients. Hence, we need to really identify who are the high-risk patients and who may have a code blue situation or being unstable when they are in the ICU or operating theatre, and start a conversation with the family early so that we can reach a consensus of what is the best risk and benefit in terms of patient care as well as staff protection, so that we won't get stuck in the situation where we need to do CPR on a patient and also risk to our staff. So in summary, healthcare staff is paramount, and we need to prepare for crisis in the midst of crisis. And if we can preempt it, we preempt it. Otherwise, we should focus a lot on training and simulation and improving our workflow to optimize patient care and healthcare worker safety. Thank you.
Thank